This is part 4 of a series of lectures addressing diabetes mellitus. These are the items that we have finished so far: introduction, physiology and pathophysiology, classification and diagnosis, evaluation of a diabetic patient, type 1 diabetes, and the last lecture we spoke about type 2 diabetes. Today we start talking about anti-diabetic drugs. This is a very nice table and it shows the various options of the various types of anti-diabetic drugs. The first and the very popular common group, actually, it is the biguanides. The biguanides, it is the prototype of it is the metformin, and the mode of action is suppression of hepatic glucose production or suppressing gluconeogenesis. The second group is the sulfonylureas. The sulfonylurea, the main action is to enhance insulin secretion. Enhancement of insulin secretion, we call this insulin secretagogue. So this is the first class of secretagogue, which is sulfonylurea secretagogues. The third group is called the meglitinides. The meglitinides also, it enhances insulin secretion by the pancreatic beta cells, and this is what we call non-sulfonylurea secretagogues. The other group is called thiazolidinediones, and it acts on the receptor level, namely the liver, the skeletal muscles, and the adipose tissue. It enhances the insulin sensitivity. And the group which follows is called alpha-glucosidase inhibitors. It acts by slowing the absorption of glucose from the intestine. And then we have the very important group, which is extremely commonly used these days, which is dipeptide peptidase inhibitors. Remember, we spoke about the incretin effect, and this is incretin-based treatment, dipeptide peptidase inhibitors, and this is a summary of their action. Enhances insulin secretion, decreases glucagon secretion. And then bile acid sequestrants, they are not commonly used. We have the dopamine agonists, also they are not commonly used. And we have another incretin-based treatment, which is glucagon-like peptide 1 agonist. And remember, we spoke about the incretin effect in full details in the last lecture. And it acts in a similar way to the dipeptide peptidase inhibitors. And then we have the amylin mimetics. The amylin mimetics, it is given by injection, and this is a summary for their action. It suppresses the glucagon secretion and it slows the gastric emptying. And then finally we have insulin. And last time we spoke about the different types of classifications of various preparations of insulin, and have another look here on the different types of insulin which are classified according to the kinetics. We have what we call the rapidly acting group, and the rapidly acting group, sometimes we call them the insulin analogs. Have a look here that the onset of action is very quick, and the peak is within 1 hour, and it lasts for almost 3 to 5 hours. And then we have another group which is called the short-acting insulin. The short-acting insulin, more or less, they have a similar kinetics regarding the onset and regarding their duration. The intermediate acting insulins, they are not commonly used, but sometimes we have to use them if we are going to be planning to give the patients the split regimen dose. Now, remember that the insulin protocols are the basal bolus, the split regimen, and finally the continuous insulin infusion. So usually we use the intermediate acting in combination with the short acting in the split dose regimen. And now the last group, which is a very important group, which is the long acting group. Have a look here on the kinetics. The kinetics, actually, you remember the curve for the long-acting group is a flat curve, and the prototype for it, it's called, the first preparation is called insulin glargine, the second is insulin detimir. Now, have a look here on the duration. It's very long duration, that's why it is given usually in one single dose, which will continue until the following day. This curve, it also shows the kinetics of the various types. The orange curve, it represents the rapidly acting preparations, and they are exemplified by the Humira and Humrog. And you don't need to remember the names, just understand the principle. This is the curve for the rapidly acting, and this is the curve for the short acting. The short acting curve here, it is represented by the pinkish color. And then we have the intermediate group, which is called, an example for it is the NPH. And finally, we have a very important group, which is the long-acting group, the Lantus and the Levemir. And have a look here on the curve. The curve is flat, and as we discussed in the last lecture, it lasts for almost 24 hours. And this drawing, this is a nice picture, which actually shows to you what does it look to have the first way of administering the various types of insulin. We have, this is the conventional type of administration, which includes a syringe and a vial. And then this is the commonly used mode of administration, and this is called the insulin pens. And we have various preparations, or actually various types of insulin pens, and each pen contain various preparations for insulins. Now, this diagram, it summarizes the overall action of the various medications used for treatment of type 2 diabetes. We have the sodium glucose cotransporter inhibitor acting on the level of the kidney and they increase the excretion of glucose. And you have here a group of medications acting on the liver, the thiazolidinediones and the metformin. They actually suppress the production of glucose by the liver. Suppression of glucose production, it means that they suppress gluconeogenesis. And then we have a group of medications acting on the pancreatic level. On the pancreatic level, in other words, they increase the insulin secretion or the secretagogues. And the secretagogues includes the sulfonylureas and this group, which is the meglitinides. And we have the dipeptidyl peptidase inhibitors and the glucagon-like peptide analog. Remember that these two groups are called incretin-based treatments. They act on more than one level. They increase the secretion of the pancreas and of insulin, of course, and also they suppress the production of glucagon. And finally, the metformin and the thiazolidinediones, they act on the receptor level, and in the skeletal muscle and adipocytes, they enhance the sensitivity of the tissues to insulin. In other words, they decrease the level of insulin resistance. This is a nice algorithm regarding how do we treat patients with type 2 diabetes. Remember, the most important item in managing type 2 diabetes is lifestyle and diet. If this step fails, then you will proceed to step number 2, in which you start adding metformin. Remember, in each step as you go onwards, the lifestyle and the diet is maintained as a crucial option in managing type 2 diabetes. And if the patient fails to be controlled by the lifestyle and metformin, and then you will start adding another oral medication to the metformin. If the patient is well controlled, you stop in here. If the patient is not yet controlled, you have one of two options. The first option in here, that with the metformin and the second agent, you add a third agent, which means in this option, you will be using 3 different types of oral hypoglycemic drugs. Or there is another option, and you omit the second agent. You continue giving the patient metformin, but you add insulin to the treatment options. This is the same diagram, but from a different perspective. Lifestyle and diet, this is most important. And then the initial step will be using metformin. If the patient is not controlled, you will add a second medication, usually sulfonylureas. If the patient is not controlled, you can add a third medication to metformin and sulfonylureas, or you will be using metformin and basal insulin. At this step, if the patient is controlled, you stop in here. If the patient is not yet controlled with the metformin and basal insulin, in this situation, you have to jump to the final step, in which you will be putting for the patient an entire treatment with insulin. In other words, you can use the basal bolus or the split regimen insulin methods. Now we come to the item of hyperosmolar hyperglycemic syndrome. In type 1 diabetes, we mentioned that the most drastic metabolic decompensation occurring in type 1 diabetes, it's called diabetic ketoacidosis. The corresponding metabolic decompensation which occurs in type 2 diabetes, it's called non-ketotic hyperosmolar syndrome. And it is very crucial to recognize that ketosis is absent in non-ketotic hyperosmolar syndrome. The reason for this, that in type 1 diabetes, there is absolute insulin deficiency. This absolute insulin deficiency, it results in massive lipolysis or breaking down of the triglycerides, and a big amount of fatty acids will go to the liver, and because of the absolute deficiency in insulin, those fatty acids will be shunted into the cell to form ketone bodies. But in type 2 diabetes, there is a small residual part of insulin remaining, and this small residual part will prevent the shunting of the free fatty acids to form ketone bodies. So a crucial difference between diabetic ketoacidosis and non-ketotic hyperosmolar is absence of ketoacidosis. ketoacidosis. But we have the same precipitating factor which can lead to hyperosmolar or non-ketotic hyperosmolar syndrome. They are the same as those precipitating factors which led to diabetic ketoacidosis. And this table, it shows the precipitating events which might lead to ketoacidosis or hyperosmolar. Remember that the most common is inadequate insulin treatment and infections, and these are the most common two precipitating causes for both diabetic ketoacidosis and hyperosmolar non-ketotic syndrome. Now, I intentionally put this diagram for you in order to remember the pathogenesis of diabetic ketoacidosis, the most drastic metabolic decompensation of type 1 diabetes. Remember, in diabetic ketoacidosis, this is a complication of type 1 diabetes in which there is entire absence of insulin, and this will result in enhanced gluconeogenesis and enhanced glycogenolysis, resulting in hyperglycemia, and hyperglycemia will lead to glycosuria and osmotic diuresis and dehydration. Most important, the complete absence of insulin will enhance lipolysis, and a horrendous amount of fatty acids will go to the liver, and inside the liver, because of the absolute insulin deficiency, it will be shunted to form ketone bodies, which are the acetone, acetoacetic, and beta-hydroxybutyric acid, resulting in acidosis. And once acidosis develops, it will consume the bicarbonate, and this will result in metabolic acidosis. But look here, have a comparison between diabetic ketoacidosis and hyperosmolar non-ketotic syndrome. In diabetic ketoacidosis, here, have a look here, this is diabetic ketoacidosis. There is absolute insulin deficiency, and this is the most important triggering factor which will lead to the formation of acetone bodies because of the big amounts of fatty acids released from the adipose tissue into the liver. But in hyperosmolar non-ketotic syndrome, the main hallmark of it is hyperglycemia. Partial insulin deficiency results in enhanced glycogenolysis and gluconeogenesis. This will lead to hyperglycemia, and hyperglycemia, it is usually severe to the extent that the osmotic diuresis can lead to dehydration and shock. And this is another table which shows the natural history or the pathogenesis of hyperosmolar non-ketotic syndrome. We have hyperglycemia. Hyperglycemia increases the osmolarity of the plasma, and this results in marked dehydration of the cells. And hyperglycemia results in glycosuria, leading to osmotic diuresis. Osmotic diuresis will lead to dehydration and shock. So the clinical features of hyperosmolar non-ketotic syndrome, in contrast to diabetic ketoacidosis, usually the onset is insidious, in contrast to the DKA, in which the onset is actually explosive. And the hallmark of hyperosmolar non-ketotic syndrome is severe dehydration. And the diagnostic criteria of hyperosmolar non-ketotic syndrome, number one, hyperglycemia. And pay attention here that the glucose level are markedly elevated, and the level is usually exceeding 600 milligrams per deciliter. And because of the severe hyperglycemia, it means that the plasma osmolarity is so much elevated, in excess of 320 milliosmoles. And because of the partial presence of insulin, it prevents the formation of ketone bodies. So the third criteria is absence of ketonemia, and so long as there is no ketonemia, so there will be no metabolic acidosis. Accordingly, the pH is more than 7.3, and the serum bicarbonate is more than 20 milliequivalent per liter. And since there is a severe dehydration in hyperosmolar non-ketotic syndrome, so it means that the most important item, the crucial aspect of managing non-ketotic hyperosmolar syndrome, is to restore the hemodynamic stability, to correct dehydration and volume depletion by parenteral fluid administration. And remember, once the glucose enters into the cell, it drags potassium with it. So those patients, after correction of dehydration, they will be hypokalemic. So you have to pay attention for the potential possibility of hypokalemia, which is sometimes lethal, because hypokalemia, it can precipitate arrhythmia. And finally, insulin therapy. And usually the needs for insulin therapy in non-ketotic hyperosmolar, it is not as high as that in diabetic ketoacidosis. This is the end of part 4, and in part 5 we will finish the remaining topics in diabetes mellitus.